Hi, this is Brian Kim. I'm going to share with you episode number 12 in the Surgical Instrument Review Series, and I'll be reviewing the Epsilon EEC-194, and this is the Framula Capsule Separator developed by Nicole Fram, and this is a little bit of a funny name, the Framula, but essentially the Framula Capsule Separator is designed to dissect the IOL from the capsular bag for IOL explantation and exchange. So again, we have a lot of different techniques to disassociate the IOL from the bag for IOL exchange. You can use needles, you can use various cannulas, but there isn't really a cannula developed specifically for this technique. So Nicole Fram worked with Epsilon to develop this technique. So I was able to get a hold of this cannula, and I used it on these two particular cases. So number one, the first case is a single piece acrylic lens into the capsular bag, and the patient had a refractive, essentially a miscommunication about what they really wanted for their vision. And so we're going to remove this single piece acrylic lens from the bag and place a new single piece acrylic lens in the bag. So you saw I went ahead and made my incisions here, and this is the Framula cannula. I'm going to go into higher mag, and you can see that the tip almost kind of has like an arrowhead configuration, but you can see that the port is on the bottom of the cannula. And so I do like that part of the design, making sure that the port is facing down. In contrast to a LASIK cannula, which faces up, you really need the port to be facing down. So I have this cannula loaded on a syringe of viscoelastic, and I was able to easily get underneath the rexus edge, push that viscoelastic, separating the lens from the bag. And this patient had surgery about 6 months ago. So again, not a terribly long time, but a good amount of time where it wasn't just right after the surgery. And remember, with my techniques, I always clean the bag of lens epithelial cells. And so whenever I do these exchanges, I don't really have a whole lot of trouble separating the lens from the capsule, but I just go ahead and get started here. I switch the Framula cannula to a standard viscoelastic cannula, fill the bag, and then I make my 3mm temporal incision. So here I get underneath the capsule and I push viscoelastic under the rexus edge, and I'm going around circumferentially. And really, as far as the cannula is concerned, once you're able to lift that initial area, that's really all you need. It's kind of done its job. And in this case, you can see that the capsule came off pretty easily on that right side. And then switching to the standard viscoelastic cannula, I'm able to separate the anterior capsule from the lens 360 degrees. And I was using a dispersive viscoelastic cannula, and I was able to push it enough to fill the fornix as well. And this is just a Sinskey hook. I could see how mobile the lens was, so I was able to just grab the edge of the lens, pull it up, pop that leading haptic up into the anterior chamber, and then using the Sinskey to dial the trailing haptic into the anterior chamber as well. Again, this gummy lens is really very easy because it tucks very easily, and you're able to rotate it into the anterior chamber as you see here. I'm just kind of rotating the lens in such a way that I'm able to cut it the way I want to. So you position the lens in such a way that I know this is the way I want to cut it. I'm putting some viscoelastic, some cohesive viscoelastic over and under the lens here. And these are the microforceps, the MST microforceps and scissors. So here we go. I go in with the forceps to my para with the scissors teeth closed. I lift the edge of the optic, grab the lens with the forceps, and then go ahead and cut it all the way. I take a really deep bite, and I'm able to cut it all the way through. Let go with the forceps and then push the lens off with the scissors because those serrations cause the lens to stick to the forceps. You have to push it off. And then switching with another set of forceps, go ahead and pull each piece out. I always start with the right side piece. And why is that? Because the haptic will collapse on itself. You can see the way it's oriented. Just grab the cut edge As I pull that piece out, the haptic collapses on itself, and I shield the corneal endothelium with the other forceps. So that's very important to make sure you have that other instrument to shield the cornea, protect the cornea as the lens is being pulled out. Rotate that second piece 180 degrees. By doing it that way, again, the haptic is oriented in such a way that it'll collapse on itself and it comes out very easily. Again, shield the cornea with the left-hand forceps. So this is the next case. This is a lens that's been in the eye for many, many years. This is a 3-piece lens in the capsular bag. Again, this is the Framula Capsule Separator. I have viscoelastic, dispersive viscoelastic syringe loaded on that cannula, filling the anterior chamber with the viscoelastic, using the cannula, and then making my incision, the 3/0 blade incision, and then using that cannula to get underneath the rexus edge. You can see that's the underside of the cannula. You can see the port. And again, it looks like an arrow tip. You know, it's kind of tapered off at the tip. It's a very low profile, so you can easily get underneath the rexus edge to, again, separate the capsule from the lens. All right, so here we go. We're going to go through the main incision, get it underneath the rexus edge, and you can see very easily, without any resistance or trouble, I was able to slide the tip of the cannula underneath the rexus edge. I'm pushing viscoelastic as I go. I'm just sliding. And again, the side edges are nice and smooth. And so by sweeping side to side, it should not cut anything. And again, gently pushing viscoelastic as I'm going around. Switching sides and going underneath the subincisional capsule there. Again, very easily able to slide the tip of that cannula under the rexus edge and pushing viscoelastic at the same time, trying to visco separate the anterior and posterior capsules. You can see, because this lens has been in the eye a lot longer than that other case, a little bit more resistance. There's some fibrotic snags as I'm trying to sweep side to side. In particular, there's some snags in the area of the optic-haptic junction on the left and the right side. I switch instruments to the Lester. I felt like there'd be better leverage with this instrument, and then using a Sinskey on the other side. So here we go. Getting under the rexus edge, trying to lift the optic and the haptic. But first, I'm using the Sinskey to pop the distal optic anterior to the capsule edge. And as I do this, I'm able to then use a two-handed technique and dial the left side haptic out of the bag. So again, I was using the Sinskey to pop the optic up first, and then gently dialing and rotating the optic-haptic junction, and this causes the left side haptic to come out of the bag and into the anterior chamber. Once that left side is up, I was able to easily dial the other haptic out by just pulling and rotating and dialing it with the Lester. Pushing some cohesive viscoelastic underneath the lens and above the lens. Again, both haptics are now in the anterior chamber. Switching to the MST IOL holder and IOL scissors. Fortunately, the lens is positioned in the right way where I'd like to cut it. So I grab it with the forceps. Again, the forceps are serrated. Very controlled way to grip the lens. And then very carefully cutting the lens with the scissors. Bisect it completely in half. and then using 2 forceps now, grabbing the right side piece, grabbing the cut edge, and again, I orient it in such a way that as I pull it out, the haptic will collapse on itself. Very careful, atraumatic, and it won't scrape the cornea, but I do have my left side forcep there to shield the cornea in case something tries to pop up and try to scratch it. But again, because of the way it's oriented, the haptic just collapses on itself and it shouldn't really damage the cornea. So carefully just rotating that second piece, grabbing the cut edge, and as I pull it out, the haptic collapses on itself, shielding the cornea with the other forceps, and that's the end of the explantation. So again, this is the Framula Capsule Separator by Epsilon. It has an arrow-shaped tip. I'm able to very easily get under the rexus edge. You saw a case much more recent, about 6 months, and then the other one was actually several years afterward. Very easily getting under the rexus edge, was able to separate the capsule from the lens. And then, of course, using a variety of other instruments, you have to still learn how to and know how to pull the lens up out of the bag and into the anterior chamber and to bisect the lens with micro scissors and forceps. I like this instrument. It works very well. I did have an issue with it getting clogged, so it's very important for your technicians to flush it really well. But compared to using a needle, which is very sharp, I think having a cannula designed for IOL exchange and explantation is really a great idea. So kudos to Nicole for developing this instrument, and I'll be using this cannula on future cases as well. So I hope this was helpful to you, and I thank you for your attention.